Okay, so we're right on time. I want to thank you for being present at this webinar. And I'm going to present myself. I am Dr. Armonia Rodriguez. I've been working here at Sanofi for quite a while, almost 9 years. I'm very happy to do so. And in regards to this webinar, it's very close to my heart. I'm not a gynecologist. I need to tell you that. I'm not a pediatrician. I'm a family practitioner. I have a functional medicine background, and that's my type of practice. And I believe it does. It does. My point of view upon treating or this specific perspective has to do with functional medicine, since we are always trying to look for more answers that we are typically given. The information that I've gathered here, I wish I would tell you it's my own. It is not. It's pretty much a summary of a lot of research for helping patients, for helping myself. I am a mom of 2. I'm happy to tell you that I'm a successful breastfeeder that required a lot of reading, a lot of research, and a lot of hard work. But I'm very happy that I'm still breastfeeding. Sadly, at this point, my baby is going to be 1 year old next week, and I'm happy to say that I probably will continue doing until, I don't know, as long as she wants to. I feel it's a very important part of her nutrition and a very unique experience in our bonding, in our time. Most now that I did come back to work, and it's a special time that we share together. So, like I said, I read extensively. I will share a lot about my own experience with other mothers. I do participate in a breastfeeding circle. We call ourselves comadres, which means co-mothers, and we call ourselves mothers of milk. And I'm very happy when I get to see them and exchange stories, experiences, and hardships. So I'm going to start, and I want this to be very interactive. Typically, we wait for questions at the end, but if you have time to type in a question while I'm on a specific slide, that's okay. I'll try to get to that at that moment, and if not, I'll tell you at that moment that I'll answer it later. Maybe sometimes your question is answered in throughout this webinar. This webinar, I don't think it's only for women. It's just that it's primarily our interest to get into this type of information. If you're wanting to get pregnant, if you're thinking about breastfeeding, or you are in that point in your life, hopefully this will save up or give you a resource to investigate further. I encountered, like I said, a lot of difficulties with my 2 journeys, because they're 5 years apart, and in those even 5 years, there's a lot of changes in beliefs, and depending on your pediatrician or where you're going for help, you might even find a lack in information. Okay, so let's start. Like you must have noticed, I am passionate about this subject. I believe in it thoroughly, and I hope you do enjoy it. So we'll start. So this is the title. So I wanted for this webinar to be kind of not boring. So I said, well, how can I explain this webinar in very layman's terms, as we would be sitting at a table with our water, with our coffee, with our drinks, getting an interactive conversation here. So I'll start this as I'm just talking to you very casually, so as we were friends, and I'm telling you I want to get pregnant. So usually you go like, well, how exciting you're want to get pregnant. So what do you do? That's one of the first questions a lot of women have. What do I do if I want to get pregnant? Well, typically we already know. We go, well, we're going to want to go to a doctor or a midwife. And what I would recommend, or what I did, you start doing a list. It also depends on your personality. I'm a list maker. So typically I always go with a list so I don't forget what I want to ask. So I went to my doctor, which is one of my best friends, and so I asked her, okay, I want to get pregnant. Should I be worried about, and you have the list in front of you. Many people don't even think about this, and it's kind of good that you don't, but it's important that you do because this is our daily life and we are doing something very hopefully beneficial to that new being that we're going to create. So what to do about it? If you have a planned pregnancy, and which is quite a few women who have a planned pregnancy, um, these are the things that one wants to avoid. Checking your type of drinking water. If you're drinking from the faucet, are you sure that is clean enough? If you want to have a water filter put in, reverse osmosis. Heavy metals, have you been in contact with which ones? There's tests for that, and these are the things that you might want to bring up with a doctor or an integrative physician if it's something that might be good for you to do beforehand. What happens if you do have heavy metals in an amount that's considered, well, in order for treatment, then I would do that first and then wait a while to get pregnant. Fish, as you know, there's a lot of information on the internet and how to approach that in regards to what types of fish are with less mercury than others, and the quality of farming fish and all of that. So like I said, this is just like a checklist, and it might even be important to check this individually when you have more time. A lot of the home cleaning products also, there's a lot of information on which are best with less toxic ingredients that are going to be, well, I changed. I really changed once I started thinking about pregnancy, and once I had my babies, I pretty much threw everything away and started from scratch with safe products, non-toxic. You want to avoid what's well, the amount of the cumulative amount that one can have in exposure, and one of the areas that you have control in is in your home. So these are the lists that are typically, there are a lot more, but this is like the majority. This is another checklist, and it's not very recommended to do this types of bullet points when you're doing a webinar, but it's just to see how a person can be overwhelmed. Like I said, what to do: get a complete physical, talk to a doctor. So go to somebody who is going to be in charge of your case, either be a midwife or your gynecologist. And so this is what I was thinking. It could be overwhelming when I was doing the past list. So some of the things that I do not appreciate is when you want to get information and they scare you half to death. That's not the point, and I usually shy away from practitioners who use scare tactics, like you should do this, this, and that, because if not, this is going to happen, or your kid. So when a person is trying to convince you with scare tactics, instead of sitting down, open conversation, trying to explain and be more of a partner in health than just telling you what to do. So that is typically how I like to work. So here's just a little thing. One has to be smart, but please don't scare me to follow your instructions. I hate that, and I was subjected to a lot of it. So what to do? Start slowly. Do the best you can when you can. It starts to become habit. When you're changing your dietary habits, going into an organic type diet, it starts to be hard in the beginning, but trust me, it gets easier. You get familiarized with labels. You know what to look into. In the beginning, I used to go a lot into, either notes. I used a little notepad or my phone to have a lot of apps to tell me which are the things that I should be wary about and how to eat. Even there's an app that tells you how the quality of fish is. So all those things I had in my phone, and I did a lot of reading. So it's better to just be calm about it. And one of the things that I always recommend is not being overly stressed about things. Take it in stride, and as more information comes in, you'll be better at it. So the best things to do is, of course, exercise. There's a lot of studies, and of course eating healthy, that's very logical. But exercise, if you're a person who has never exercised, or you've always been sedentary, it's not the time to start doing aerobics or doing something that you've never done. So talk to your doctor, or what I said, midwife, and see just even walking. But it is important, and it's a good health benefit to start doing good exercise while you're pregnant or wanting to get pregnant. What type of pregnancy-related supplements are indicated? And this is one of the things that I struggled with when I went, even though I am a doctor, it is not always a good rule of thumb to treat yourself. And you always are open to opinions and about the expertise of other people. So that was what I tried to get when I was searching with my, who was in charge of my pregnancies. My friend, my gynecologist, who's really good, and don't get me wrong, but she is very allopathic and goes with the typical standards, which I respect. So I brought her my list of supplements that I was considering and even taking already, and she really drew a blank stare. And I got a little disappointed because she told me, no, you know what, those are a lot of supplements. You probably just to take the prenatal, that will be it. Well, the typical prenatal, even if it's the standard issue or the one you get at most major stores, it's really subpar. You really want to look into a whole food supplement, of course organic or a GMP certified supplement. That means pharmaceutical grade. You are giving yourself a nutrition for you and your baby, so I wouldn't go with the typical over-the-counter things that you would find at CVS, Target, Costco. Please try to avoid those. You don't want anything synthetic or anything that could be contaminated. I use a particular brand of supplements. I use a lot of USANA, but if you go and do your research in any particular brand, as long as you follow those guidelines, you'll be okay. Typically also they do blood work, and you would notice if you're deficient in certain nutritionals, then you would of course do those. Of course, a healthy diet without processed foods, the better. You cook it on your own without getting anything from a box. Vitamin D typically and ideally should be checked. You can do a blood test and then you get your number, and then depending on the level that you have at present, there's a calculation that you can do how many international units you need. If a person is deficient, let's say you get your blood test done and you're at a 20, which is very typical that I find in my patients, we would need to put you in at least 10,000 international units. It sounds like a lot. It is not. There's, like I said, a very well-studied calculation that we can do to get you to an optimal point between a 50, so consider it a 50, 70, or even up to 100. But if you're deficient, it is important to take vitamin D, maybe at least 2,000 international units, 4,000 international units a day is safe. Calcium. A prenatal vitamin, I put them in, so if you're new to supplements, I don't also want to recommend overwhelming you. There's a lot of things that happen in pregnancy that you might get nauseous. Even the smell of the pill or the omega might be too strong for you. If that is the case, skip them throughout that day. Try to eat like a green juice or eat something very healthy, but it is appropriate to be supplementing while pregnant. Iron is also, if you need it, we tend to need it even if we're not deficient, just because of also the pregnancy. Iron by itself can also bring other side effects like constipation. I found, depending on the type of iron that you get usually a chelated form of iron would be best and tends not to constipate. Okay, I'm seeing here a little question. I'm going to pause for a bit. Let me see, Doctora. Okay, no, that was somebody else asking that couldn't hear me. Can everybody hear me well? I just need another test check here. I got a signal that I was possibly not being heard. Can everybody hear me all right? Okay, perfect. Thank you, thank you. Okay, I got some feedback. I'll go right back. Perfect. Okay. Oh, I skipped one. So here. So some of my slides are going to be very, very obvious, and you're going to go, well, I know that. I know you know this, but it's always good to have reassurance, and more so when you're doing things by yourself in your research. So this is obvious. While pregnant, of course, we need to eat healthy, rest. and take it easy if you are working. And this one, I think it's easier said than done if you also have a full-time job, as I was when I was pregnant. Sometimes even your coworkers might forget that you are expecting, and stress targets you differently that they would. And of course, we're growing and our weight is shifting, and there's other uncomfortableness that go around it. But listen to your body. Listen to your body, and don't be afraid to talk to your boss, your coworkers, that you might need a little extra help. There's no wrong in asking for help if one needs it, okay? The sleep quality, of course, again, something really obvious. Important of having your good quality sleep. I have another webinar that talks about sleep altogether, but it is important to get your 7 to 8 hours of good quality, dark room, no interruptions. It's hard to, I know, once you have kids already, it was hard to get my own, but try to get that. You know you're going to need it. Okay, so once you're pregnant, these are symptoms not to ignore. It's quite common to get a little achy here, achy there, but bleeding, once you pass the first trimester, you might see a spotting. Some spotting can be normal. Sometimes in the first month or first 2 months, there might be a day to which you spot. In certain pregnancies, sometimes there's a little blood clot that gets collected between the placenta and the uterus. And as the uterus grows and the baby grows, the placenta moves a little bit, and that little blood clot that was captured might be released. So that could be it. But that is typically a one spot, two spots, and it's over with maybe a cramp, but no more. So if you are bleeding at any point, or something that in your gut's telling you it's not right, always get checked. Severe nausea and vomiting. There is, of course, a state called hyperemesis gravidica, which means that the severe nausea just does not stop in your vomiting. Sometimes women need to be hospitalized because of dehydration. So again, if this is something not common, even if you had a little bit of nausea, morning sickness, but if it elevates, go get checked. Baby's activity. Once we are able to feel our baby inside, typically around the 5th month and beyond, if the level of kicking and movements lowers, also get checked. Contractions in the early trimester, headache that doesn't go away, and then this is more important mostly at the end of the pregnancy. When there, and more so, there's past history of high blood pressure, diabetes. All of those should be considered even a high-risk pregnancy. And again, there's a little, this webinar is trying to talk briefly of certain things, because by itself, this is another hour. So hopefully if I don't get finished, or there's more questions, or if you want to hear more about this particular subject, you can let me know through our Facebook page or through email, because we could do a series, because this, like I said, it's a lot of information. Obviously, when your water breaks, if you have blood pressure, painful urination, again, go to the doctor. If you have a urinary tract infection and it goes out of control, it can trigger also contractions. So it is important to anything that is an infection to take care of it. As you can see, other very important keys here: chills, fever, difficulty breathing, depression. Depression, again, is another sensitive subject. Typically, if you had a diagnosis already of depression, it's good to talk to your caregiver with this. And if they're going to continue certain medications, if you're on medications throughout your pregnancy, they might change it if it's one that doesn't go well with pregnancy. But it's important to always be, that's why all the checks, as you know, you're continuously going at least once a month. If you have a high-risk pregnancy, you might go more. So it does depend on the individual case. A routine checkup, typical once a month. In the beginning, they'll of course weigh you, do vital checks, check the baby's heart if they're doing. In the beginning, they will ask for a pap smear. Strep B is a culture that they tend to do about a month before you're going to deliver, if it's a planned, or if everything is going well for a vaginal birth. If you have strep B, they might give you antibiotic treatment to treat it, and so that the baby does not get contaminated while it passes through the vaginal canal. They'll do always a urine test when you get there. What that is for, to check if you have ketones in your urine, is to also help prevent if there's any symptoms of preeclampsia. And typical blood tests that are done at least 3 times throughout the pregnancy are the CBC, the blood chemistry. They will check for infectious diseases on the first trimester, and then the glucose test and the glucose tolerance test, which are not my favorite. So even if you don't have a history of diabetes, they will do that, and those are uncomfortable. Okay, so this is key. You don't typically, well, even myself, when I went to the doctors, I always had a list of questions, and mostly because I was reading, right? You're reading and you want to make sure what you're reading is correct, or you want to get the input of your physician. Don't be afraid of being categorized a bad patient or a troublesome patient. It's your right. It's your right to challenge us, to ask us, to see why we're doing stuff. It's always good to have an open conversation. I really like it when at least I get questions, because it means that you're interested, that you're going to participate, and you're challenging me. Just in case I don't know something, I'll go and read it. I know it's not the norm with physicians, but please do not get intimidated. Just because I asked, I got a lot of things that I wouldn't otherwise, because typically there were things that not people want to do. So it is important to be true to what you want, and don't be afraid to ask for it. So these are some questions that you want to do or pose to your doctors. This is also another typical question: to how much weight to gain. This is something that sadly I wasn't able to follow very much in my pregnancy. I gained always a little bit more. I went from my first pregnancy, and it was healthy food. It was not because I was overeating that much. It's just that, well, I listened to my mom in this case. We just tend to get heavy when we're pregnant, and then we lose it rather well. But I gained from 135 pounds that I was pre-pregnancy. I ballooned all the way up to 200 pounds, and I'm kind of ashamed to say it out loud, but it was a very healthy pregnancy. But it was a struggle to lose it later on. I don't know if it was a reason why I struggled with baby blues later, but I didn't do the same with my second pregnancy. I was a better patient at the second time around. But it's always healthy to at least gain, as I says, in general, 2 to 4 pounds during the first 2 to 3 months, and a pound a week for the rest of the pregnancy. It is important to talk about weight gain here, because if you gain a lot, you do increase your chances of getting gestational diabetes or making just more complications for yourself and the child. So it's really good to stick to a good diet habit and not indulge, as I learned the hard way on my own 2 pregnancies. So this is something that I always like to tell. Where does all those pounds go into? So typically a baby can weigh, 6 to 8 pounds, and a normal baby weight, the placenta, another good 2 to 3 pounds. Some amniotic fluid, breast tissue. Our blood supply also increases. Stored fat, we also get that a little bit, and the enlarged uterus. Typically when the baby's out, so as soon as your baby's born, you will eliminate the baby, the placenta, the amniotic fluid. The extra blood supply tends to go away with a little bit of weeks. And of course, the enlarged uterus, that goes down slowly, but by the end of 6 weeks, the uterus tends to go to normal size. So if you are good about your weight, you should be able to eliminate the excessive pounds in relatively less than 6 months. Not that I want you on a strict diet, and more so if you're breastfeeding, but we'll talk about that later. So generally safe exercises that I have here, if you've not been doing anything, walking is always good. Maybe just a little bit more briskly if you want, but not necessarily. Swimming is a really relaxing. I enjoyed that throughout my pregnancy because I didn't feel the extra weight, and it was good exercise. And good if it was a hot summer month. Yoga, I also did that myself. It was really good. It relieved extra pressure that I had on my lower back. I've had friends where they're CrossFitters, and this is where I get amazed. Typically, you wouldn't think of doing CrossFit. I would not. Those are the exercises, if you're not doing them already for a couple of years and you're good at it, your trainer and all that, you should not do these. If you're already a runner and another type of intense exercise and you're supervised, I'm all for it. I've seen women with 8 months in their pregnancy and they're doing amazing stuff. It's just jaw opening. Hot yoga is typically not recommended even if you've been doing it, so because you tend to get overheated anyways and it's really dangerous for your baby, so I would not recommend hot yoga. So as soon as the date starts to arrive, there's certain things that are good to be doing. There's the nesting phase, and you probably don't know. It's just things that you start getting organized, maybe for your husband a little bit too paranoid or too stressed. But this is just normal. It's a normal preparing time. The birth plan, I had my own birth plan for my 2 pregnancies. My second pregnancy went a little bit more to plan than my first, although there's always a surprise. So talk to your gynecologists or midwives. My experience, even though I did not have a home birth, that I've always, and I think I'm just going to stay with that desire since I don't plan to have any more children, but my ideal birth plan was a home birth in water, and I did not get to have that. So if you are having a hospital birth, it tends not to go as planned. There's another big load of details I can share with you there. If you want to have a little bit more control and have a normal pregnancy without any expected complications, if you are willing and want to having a home birth, that would be my best recommendation, to have that. It should not be a traumatizing experience. It should be something gentle and loving in a caring environment. And some hospitals are better than others. I don't want to generalize, but you start to get pressured. So overnight bag, there's a lot of lists out there on the internet that you know what to pack. Make it quite simple. You don't need to pack. My first bag looked like a like a week stay, and my second pregnancy was really just a couple of onesies, the clothes that I was going to bring her with, some basic care essentials of mine, and I didn't even take a change of clothes. The clothes that I came in were the same ones. Oh, clean underwear, of course, but nothing in particular. So I became a little bit more practical on my second run. So vaginal birth. I don't want to sound that I'm choosing one over the other. A vaginal birth does have advantages and over C-sections, but I don't want this to become like a favoritism for one or the other. A C-section, if it's indicated, everything has an indication in medicine. If you get the criteria to have a C-section or there's complications, that's fine. What I am against is the overuse of C-sections, either because of doctors' convenience or mom's convenience. Then is when I kind of get very respectful, but still, it's not the natural form. And by having a C-section just because, you're actually making yourself prone to a lot of complications that could be unnecessary. There's more risks involved. So that is where I stand in that regard. So I will talk specifically about vaginal birth, although C-section will be mentioned later on, more so for the baby's benefit, some things that you can do. So these are some of the benefits, as you probably read while I was speaking. And this in particular, now I'm so glad most hospitals now, if you're deciding on a hospital birth, are doing this now. They even have been trained, like the hospital where I had my 2 babies the first time around. They didn't have any even lactation consultants, which was very detrimental in my end. Well, not detrimental, it was just harder for me. And on the second time, they've gone through all this training and they encourage this. So this is something that in my birth plan that I talked about it. I started the conversation with my gynecologist, and he said, "Oh no, we're doing that now." And I said, "Oh, I'm so relieved because I didn't I wanted a certain thing to go." And he said, "No, no, no. This is exactly what's going to happen. Skin to skin contact." When I was in, well, a long time ago, almost 20 years ago, in medical school, we were taught about kangaroo mom, or at least in Spanish, that's how it translates. And it's a system used for preemies. When one was in the NICU, in the intensive care unit for babies, for premature babies, they started to put skin on skin, the babies on skin on the mamas, or even surrogates, the nurses, or they saw that these babies thrived much better in comparison to babies who they were not doing that to. So it's a whole program. You can look into it in the internet. There's a lot of studies on it, and now it is not reserved only for the preemie. It's for everybody. So this is one of the things that I was so grateful to have with my second born. Because as soon as they were born, before mine were vaginal births, and they would show her to me like, "Oh, give her a kiss," and they would scoop her. They took her right away, and so I got her like 40 minutes after. It seemed like an eternity, and even though I had written and said to them verbally that I was going to breastfeed, they gave her to me with a bottle in her mouth. It was so, I was really angry. But anyway, the second time around, they left her as soon as my daughter was born. They put her on my chest and they left her there for almost 2 hours. It was amazing. Well, I'll talk about it later. I'm sorry, I get carried away. So this is one of called the sacred hour, exactly what I was talking to you about. So it says, the manner in which a new baby is welcomed into the world for the first hours improves its consequences. It says here, there's a lot of the benefits of the greater respiratory temperature, glucose stability, there's less crying. Babies tend to go and root for the breast, so you'll have a better outcome if you're planning to breastfeed. In fact, my baby right away took to the breast. It was amazing. So it was one of the best memories that I have. After a while, when the bonding has somewhat and she's eaten, that's when now nurses come in if you're in a hospital, and they will do the checkup. So an APGAR score, just in case it's some of the medical terms here, the APGAR score is done at birth and then around 5 to 10 minutes, and it's a scoring system that is used to see about how the coloring, the crying, how active the baby is, amongst other things. And the top is a 10, so babies get a 9-10 APGAR score, really good. Births without any complications. An APGAR lower than that tends like an 8-8, 7-8, tends to be babies who are a little bit more bluish, are having trouble like moving around, crying, that sort of thing, and they could end up at the NICU. They will do a hearing and eye test within the 24 hours. Vaccines, also another sensitive subject. I didn't want vaccines, so it was kind of a struggle in the hospital, but they respected that. They typically give a hepatitis B shot upon birth. In some hospitals, I think even polio, but in this one was hepatitis B. So I didn't want it too soon. So I said no, and then the rest of the typical things that are weighing them and photo ops. There's another thing with the umbilical cord, something that is also relatively new, is that once you cut the cord, once it stops pumping. Once the cord is completely empty, that is now showing a lot of favorable studies that to decrease anemia in the newborn. So if you're going to that process, bring it up with your doctor, and that's again one of the things that I asked, and he told me, no, we're now doing that standardly. So some of the more educated doctors would agree with that and not cutting the cord before it stops beating. And it's emptied out in its blood. Okay, so now going into breastfeeding. Again, very passionate about it. I am very strong opinionated about it. I think most women can successfully breastfeed with certain rules. And the rules is pretty much support. People who have support have greater chances of successfully breastfeeding a child. It's very hard work. At least, well, the majority, like I said, I belong to a lot of groups, and some of the troubles that we encountered, at least in our first try, was a misconception of how easy it was going to be. I had no one before in my family. Nobody breastfed my nieces or nephews. I'm the oldest in with my sister, so she hasn't had kids. My mom was, I was not breastfed as a baby. Her doctor told her that formula was best, and that was routine between the 50s and the 70s, which I was born in the 70s. So my mom was taught that breast was not best and I should be formula fed. And I was, and everything went fine. I was not a sickly child or anything, so I'm not against formula feeding if you need to. It's just that if one has the desire to breastfeed our children, we should have the support and not be harassed or getting unsolicited opinions. It's already hard enough to want to do this and to successfully do this, that we need somebody else's opinions or why are you doing that and it's yucky or whatever. So this is where I like the conversation to be very active, because it's quite common to get these opinions and a lot of women have it. So first things first, so I do recommend, if you're planning to breastfeed, to read about it, look videos in the internet. There's a lot of information. Like I said, I have on my last slide a list of resources that I went into and that I used for myself when I was struggling. Lactation consultants are your best friends. Something that I did not mention that I wish I had is a doula. A doula is a woman who has gone through training and is a person of support through the pregnancy, throughout the delivering of the baby, and after for postpartum help. There's studies again that show that women who actively have a doula through childbirth and later on have better success in lowering complications throughout the delivery and better success at breastfeeding. So if you are able to get a doula, I would strongly advise it. That's something also that, well, my mom said that she was my doula and she was present in my delivery, which I do appreciate. And besides getting all the information, videos, all that, the latch is key. There's nothing better than getting a good latch. If you get a good latch from the get-go, or at least within a couple of weeks, you will avoid, hopefully, most of the complications. So it is important to see the videos, to get a person to help you to get that good latch. So let me go into the next slide. So one of the things to help you get that good latch, like I mentioned before, the skin-to-skin contact, that helps immediately. And even the baby starts to root, like I said, towards the breast. So that is very important. Oh, wait, I'm sorry. I'm going here, touching other buttons. This is, of course, an example of how to get it. And this is, again, something that I'm missing, that it could be very interactive, and how to get that good latch. A good latch, the baby, and this is where also you probably have heard, or at least I've heard it a lot, that if you're full-breasted versus small-chested and who has it easier, it's really not supposed to matter. Mind you, I am very full-breasted and I did struggle a little bit, and then but once I got a good latch in, it didn't matter at all. But as you can see, there's the figure here and how the mouth, where's my pointer? Right here. The baby's mouth should cover mostly the areola. Again, depending on your breast size, if you have smaller breasts, it will cover it completely. If you have very full breasts, you will still see a little bit darker area of the areola. I'm sorry, this actual slide is not, it's too blurry. But here's another one. And I like the one that if you can see with the baby. This is how a good latch seems. I get excited when I see these good latches. That means that that baby it's covering well the areola. It's if they get only the nipple, that's when they start drying it out, and then that can create the of course pain and oh, I'm missing the word in English. The little cuts and get mastitis, and so that's very painful by itself, and you can start to bleed. So this good latch that this baby has here is what you want to strive for. As you can see here, it's really good latch. This is what you want to avoid right here. And it can happen. It's happened to me. It's in my first pregnancy. My daughter was not getting a good latch, but this is where now, versus my second pregnancy, my first child, like I said, they gave her to me with a bottle in her mouth, which that could be that it's called, well, of course, nipple confusion. The bottle is much easier to grab hold on, and she struggled. I struggled for a week, and I was not ready to quit because I'm very stubborn about it. But it really was hard. So I started to pump and then give her bottles, and so it created a whole lot of complications until about 3 weeks into it. I threw all the bottles away, and I just managed with my breast. But I had the nipple confusion. So if I could recommend something, I would tell you try not to give her a pacifier or a bottle. So the typical positions, there's 4. Pretty much they're variations. The cradle, as you can see here, how the baby's head is resting into the crevice of inside of your elbow, and then you're holding your breast with your other hand. So this is something that is comfortable on a chair. That's also something very critical and important, to be as comfortable. Mom has to be comfortable first, because you're going to be there quite a while, maybe 30 minutes, 40 minutes, depending on the baby. My first baby was really good on every sitting, so I would get a 30 to 40 minutes with her. And my second baby was a quick eater, even up till now. So with her, it was 10 minutes. It's very different. It frustrated me in the beginning because they were not the same. But just so you know, there's different types of babies and how they eat. So this is something that you got to get comfortable, and this could be a good position for you. Where's my pointer? This is a better picture of what a cradle hold looks like and how it should be. The cross cradle, it's pretty, like I said, it differs because you're not holding your head of the baby with your arm. You're actually holding it with your hand. So this is also a better position if the baby's having trouble. You got to hold his head a little bit more steadily and guide him a little bit more. So this might be a good position for you. So this is a cross cradle. As you can see, the other arm is for the body, the hand is right here for the head, and you're guiding your breast towards the baby's mouth. Like I said, these are better pictures. The football hold is actually my favorite. It was the most comfortable for me. This is also recommended for women who have had C-sections because the baby's not resting in your abdomen. This pillow here, as you can see, you can find it in also a lot of the baby stores and even out some retail. They're actually wonderful. I had also a boppy type of those, those typical half donut. Those were very comfortable as well. And the typical pillows behind your back, you have to position yourself even if you're in your bed. But this one, as you can see, the baby's facing outwards and you're carrying him, and so this was my comfortable. So here as I place the pillows behind, sometimes, like I said, it sounds like common sense. With the baby facing towards you, draw him close, put his head in your hand, and then the body towards the back of your body. So this is comfortable. Well, I said the other one was my favorite, but no, I'm sorry. This is actually my favorite because sometimes you're very tired. And as soon as your baby can do this, this is for me, like I said, the best position because I was able to lay down for a while, even sleep. Although there's a whole conversation about co-sleeping, but this is something to get a little bit of rest for both of you, and then the babies get down to get sleep afterwards. So here, there are typical things that we might encounter in regards to complications, sore, cracked, or bleeding nipples, or areolas. Some lactation consultants do not like the breast shield. I didn't use it myself. Sometimes they're even recommended for inverted nipples. Again, some lactivists do not like them, but I did put them. I believe what works for you works for you, and it's a matter of trial and error. If you tend to need them, because if you have a cracked nipple or areola and you want to continue breastfeeding, which is advised, you want to protect yourself. So I had friends tell me that they needed it and they used it and then just discarded while they didn't. Cold packs are going to be necessary. Mostly, I'm going to talk a little bit more into this about engorgement and of course, overproduction. An ice pack could be your best friend. So we'll talk about that. Ibuprofen or acetaminophen for pain. Usually the pain, once you deliver your child, for those who haven't had kids, the first thing that comes out is colostrum. Colostrum typically is like the first day or first 48 hours, and it's very important nutritionally as for the benefits in your immune system for your baby. So if you don't plan to breastfeed, if you can even give them those 48 hours, you're going to increase his chances for less allergies, improve immune function. There's a lot of benefits for it. So I would even consider having those or pump them out and give them, but the colostrum is extremely important. So after the third day, typically is when your milk comes in. So when your milk comes in, this picture in itself that looks very blurry. I actually did not see this until the beginnings of last year, that I wished I would have seen 5 years ago, because you're always thinking if your baby's eaten enough. And if you researched it and you want to know, or you go to your doctor and say, do you know if he's eating enough? Usually they tell you about how many wet diapers the baby's supposed to get and how many stools a baby's supposed to get. So, and that could be even confusing because not all babies are the same. My firstborn would poop every time she ate, and I was very grateful for that because I would have been a mess if I didn't know. With my second baby around, she didn't poop. She was a typical breastfed baby that could not poop in a whole day, and that was stressful enough. But she would pee very frequently. So this is a guide, so you don't stress about your first days. It's comparing the size of the baby's stomach to the amount that they actually need. So this is very important when one is struggling with low milk supply, is to see if you actually do have low milk. We can't measure the amount of milk you're producing by the amount that you're going to be pumping, because it's not the same. The more successful pump, the most successful pump that we have is our baby. So don't get discouraged if you pump and you're just having an ounce and you're going that my baby's not eating enough. No, no, no. It's all the contrary. The baby will stop eating when it's full. So the first month is very important, and more in order to assure your milk supply, is that the baby does not have a schedule. It will eat at, we call it libre demanda in Spanish, meaning that a free demand, a free will. You place the baby as soon as it's easy, and yes, it is tiresome. Yes, you do get tired. That's just normal, but that's how it is. And if you really want to continue breastfeeding, the first month, it's the hardest, but it gets better. So let me go to the next slide. So these are ways to also improve a low milk supply. Check latch and position. Breastfeed often and let your baby decide when to end the feeding. Offer both breasts. Also, there's changes in that recommendation. They used to recommend 30 minutes on each breast, and now you can even see that I differ on that recommendation because there is a thing of hind milk and fore milk. The fore milk is the more liquidy milk, the one that has quenches the thirst, it has immunoglobulins. And the hind milk, what it does, it's a more fatty milk, and that's one that will give your baby the feeling of being full. It's the fat, the nutrients. So I would prefer if you empty one breast and then offer the other, and if the baby still wants that one, or pump the other so you don't mismatch. Try not to use pacifiers. My first baby, again, was a pacifier baby. I tried, and I'll be honest with you, I tried to give a pacifier to my second baby. She did not take it, thankfully, so I'm not struggling with that. I'm not against pacifiers. I really remember how wonderful a pacifier was with my first baby. It calmed her, it soothed her, and I didn't struggle a lot in the car or anything like that. My second baby just doesn't know what to do with it when she was offered it. So I've had both experiences. And again, no schedules for feeding the baby, at least on the first month. Then after what fits your schedule, it's let me not go back and rephrase it. Again, giving the example of my two babies, my first baby was a scheduled baby. I had fed her after the first month was a free will, and then I was recommended to put her on a schedule, and I followed her, and she did well. And my second baby, up till now, she will, if she wants milk, she will just let me know, and I'll still give her at when she wants to, because you have to think of it. The first 6 months when you're exclusively breastfeeding, milk is not only what you're going to give them to eat every so often, it's also their water supply. So if you're not going to wait 2 hours if you're thirsty, right? So it is very important to feed your baby when they ask you. Again, take this advice and apply it as you best see fit. This is just my opinion, as you will encounter many. But the oversupply, it's another problem, and you don't typically hear about it. I had this particular problem, and when I shared this problem with my friends, they would say, oh, but that's not a problem. The problem is not to have enough. But let me tell you, it can be a horrible problem, because when you have a lot, there's a lot of, it hurts foremost. That's the first thing. Of course, it hurts a lot. If you get engorgement and oversupply, your baby can get a lot of gas because they're getting a lot of the fore milk, and they get full with that, and they don't get the fat in the hind milk. So it can create a lot of problems, even colic for your baby. And there's not a lot of information on oversupply or fore milk and hind milk. At least that's what I encountered. So in the resource section, there's a doctor called Jack Newman. He's a Canadian doctor. So his page saved my life, because I was getting really desperate on my experience on the second time around. But again, like I said, there's a lot to talk about that. So I'll try to stick to the slides, because I get sidetracked. So with oversupply, block feeding works. What is block feeding? Meaning that you will breastfeed for only one side for hours, meaning 2, 4, or 6 hours straight. Whatever works for you. I had to block feed sometimes even for 8 hours straight on only one breast, because if you stimulate also too much, if you breastfeed, because you have a lot of full breast, so you want to, that's what my mistake. I would use the breast pump to alleviate the pressure, and that sent the signal to my brain that I needed more, so it made things worse. So again, I'll guide you how to do that. There's more slides on it. So talking about that engorgement. So engorgement is when your milk comes in. That is normal for every woman to experience. You'll always remember those couple of days. Sometimes it can last longer. For mine, it lasted a week. So it makes you feel really lousy when you have this issue. It's really uncomfortable. The breasts can become rock hard, very red and tender, and it just makes you feel really lousy. So these are things that this is normal. 24, maybe 48 hours. As long as the baby's eating, they feel better once the milk has been expressed. But if it continues, like I said, for me, it was almost, I feel like the 7 whole days. I would need to go into the shower. That was that horrible, because it was to let a little bit of the warm water hit the breast tissue so I could leak. I don't know if it's too much information, but it's probably going to be important if you have this. So to let the milk flow a little bit, or pump a little bit, not the whole breast, because again, that can make things worse. There could be low-grade fever like I experienced, because there's just a lot of very uncomfortableness. So here, what to do before nursing. So gently massage the breast, I'm sorry, this is bad grammar, from the chest wall towards the nipple. Cabbage leaves, you can use that. I'll have the next slide of how to use those. Or cold compresses, like I said, this could be your best friend. I would get ice packs of those little gel type of packs that are longer that I keep in the freezer, and I would put them over my breasts. And those would really help and alleviate the pain. Standing in a warm shower right before and hand expressing milk, not too long, maybe 5-10 minutes, and if that's not successful, then breast pump. There are teas that you can use, but I don't typically recommend those, because then you can go to the other side of the problem. This is what you need to avoid: excess stimulation. Heat makes things worse. That's which is only a warm shower. Like I said, only a few minutes. And do not restrict liquids. That has no impact on your breast fluid whatsoever, and you will get dehydrated. So you need to continue drinking your water. So it doesn't make sense to restrict any liquid. This is a slide that tells you how you can use cabbage leaves. I remember when I got this, I did not have green cabbage at home, so it's a whole debacle just to go tell my husband, please get a cabbage, and then getting phone calls from the store, what kind of cabbage? So if you can have cabbage already in your house, that will make things easier. So this is a slide that can tell you that. And then other complications, I'm going to breeze a little bit faster since we're running out of time. I'm not going to end it until we finish, but just in case you have to go somewhere, because it's supposed to be an hour, but I'll go a little bit faster. This is other problems that you can have. There's symptoms, of course, of mastitis. Mastitis means inflammation of the breast. That's because engorgement becomes a complication, or this can happen anytime after when you're breastfeeding. Okay? Mastitis can also become a complication, get a duct clogged or anything like that. I found this, and this is again another of the community of midwives out of Toronto, about potatoes. I have not tried this, but I found it interesting, so I decided to add it to the webinar just to see if you have this experience and you use potatoes. I will gladly want to hear about it. Thrush is also one of the common complications. I do not have personal experience with this, but it's, as you know, thrush is a yeast infection. It can grow around your breast because typically your breasts have to be hurt first in order for you to get thrush. You don't get it right away. So typically happens when there's been complications with the latch. And this is what the areola could look like. Some could look better, some could look even worse. I just wanted to find one that was very characteristic of what thrush looks in the nipple and what you can see in your baby's mouth. Sometimes babies who are, of course, drinking milk might have a little whitish tongue. That's normal. Just you can clean it with a little cotton or a little, what's it called? Well, something to clean the tongue, and you'll notice if it's thrush. Thrush does not clean out. And there's also, you need to go to your doctor or midwife, and they can guide you to how to treat it. Flat or inverted nipples were a very common factor for women to not breastfeed. Like I said, and if you notice what I said, that they don't need the nipple, they need the whole areola, so it doesn't mind too much that you don't have an inverted nipple. As long as the baby has a good latch, they massage over the areola and milk will come out. And sometimes with a couple of, if it's an easy to invert areola, even the breast pump can help you lie it out, or in the case of breast shields, they can help you there. Other possible complications that one can encounter when having difficulty breastfeeding, besides the top ones, I want to talk about tongue tie. Tongue tie is a picture you're seeing there is when the membrane beneath the tongue is a little bit longer and still connected, so the baby cannot latch well. This is something that you need to seek help with a lactation consultant or even the doctor, because they need to nip that little membrane out in order for the baby to latch well. It's not very common, but it's one of the main reasons why babies are not getting a good latch, and you might encounter problems. The fore milk and hind milk imbalance was one of also my complications that I had. And this is where block feeding improved it. Cleft palate or cleft lip, those are very specific situations that you do need the consult of a lactation consultant or even your doctor to repair. Reflux is not a reason to stop breastfeeding. Again, this is something that a lot of my friends say, oh, my doctor said that my milk is causing harm to my baby. That's not, that's actually really a lot of misinformation. What is not better for reflux than the mother's own milk? If you go to formula, it's something that is going to cause possibly more harm, and reflux can be quite common as long as there are types of reflux. The one that you just spit back, that's the typical normal. If your baby's shooting up the milk, that may mean that they have a little problem with their sphincter. So again, go see your doctor and check what's that specific issue. But reflux is not, or jaundice are not reasons to stop breastfeeding. On the contrary. Let me check the next slide. This is where I go into co-sleeping. So I don't see, like I said, I'm going to finish the webinar. I don't want to take time away from you guys since we did do an hour. But co-sleeping, if one is breastfeeding, tends to, it's like they complement each other very well. Again, this is very controversial. A lot of doctors go against it. It goes with attachment parenting, but you don't have to be an attachment type parent to co-sleep. It just means that this is what's useful for you. I hate to categorize people depending on how one decides to raise their baby, but co-sleeping also has its benefits, as it has seen some improvement with SIDS. But again, you'll find a lot of studies again killing the fact of co-sleeping because it says that it could make SIDS worse. There are some guidelines. Of course, you have to be a responsible parent, the good stable mattress, not be an influence of anything. So it's just common sense. So this is the cons of a lot of the arguments that for people who do not want to co-sleep. And I found this, okay, there are of course reviews about the importance or how well do babies do with co-sleeping. So you can see that later. And this is a UNICEF guide. I actually just copy pasted this. You can go to that website that's right here and you could go through it. And this is what I had in my bedroom. It's a co-sleeper. And it was a life. I miss it still, but this is well, typically my arrangement at home. I had this little bed for me, and it just this is a great leaflet with very common sense bullet points to the point of what you do if you decide to co-sleep with your baby. And I wanted, again, like I said, talk to you a little bit more about the postpartum. I think I'm going to ask for another series on baby blues and postpartum depression, postpartum anxiety. This is something that I found also that a lot of women do not discuss, are afraid to discuss, or embarrassed. Something that I did encounter a lot, well, since I've had my kids, is that a lot of the conversations could be very taboo or very sensitive, and people get very guarded. So I want to provide an environment where you're a very open environment. You can ask your questions, and if you have certain symptoms, to get help. So baby blues are a pattern of feelings that one can get right after childbirth. It's not supposed to last more than a month or even less, but as you can see, if this surpasses that supposedly normal time is when we have to be more careful, more proactive in regards to the mom's health. Because it could interfere how that mom takes care of the baby. Although love is always there, it's just that we tend to be anxious and it can take a little bit more hold of us than usual. So typically, like I said, it doesn't last more than a month. Postpartum depression or anxiety can continue, so talk to your doctor or midwife, and it's important to ask for help. My first pregnancy, I tried to do everything for myself. I got overwhelmed, and on my second time around, you get a little bit more, I got a little bit more comfortable, and I did ask for help, and I got a better outcome for it. So this is a small list. There's much more. If there's time, I'll do another slide. My favorites are Kelly Mom. Wellness Mama, besides having breastfeeding tips and all that, has a lot of wellness resources and do-it-yourself creams, and it's a really good website. The one who really helped me is this Breastfeeding. It's a Canadian doctor, like I said. I put here his name, and you can go into his website, and it's there. He has a broad list of resources. Like I said, too extensive for me to share. But if that would be also one of my best recommendations. The Alpha Parent was one of my favorites. If you go into this one, she is very strict. So this is a website that is for the attachment parent, the parent who wants 100% natural, no vaccines, no stroller. She really I don't want to. So it's a one-sided area. Like I said, I don't like to categorize how we choose to raise our children. It's just you take tits and bits what works for you, and hopefully it's for the best of your family and for yourself. The Leaky Boob was one of my. I'm glad to call her my Instagram friend and Facebook friend. She helped me. She's also a doula, and she's very into breastfeeding, and she has an amazing website. And so if you have any questions, this would be the time to ask them. And I'm seeing a list of questions here. So I'm going to go up, and it says here, what suggestions do you have for a mom in late 30s who has a teenager and wants to get pregnant but having difficulties? What should she do? Do you see USANA vitamins may help to get healthy enough to become pregnant? Carolyn, I did use USANA myself. When I started working here, I encountered many stories with women who were starting to do USANA and within a couple of years started to get pregnant. Why could that happen? Maybe because there were nutrient deficiencies. One of the biggest factors that I've seen when women are struggling, like I said, I'm not a gynecologist. This is what's come to me in my medical practice. It's when they've had chronic stress, and wanting to get pregnant adds to that stress, and that for some, well, I can go into the physiology, but that for some reason, for explanation purposes, interferes with getting pregnant. A typical classic example of that is for the person who adopts, and after they adopt, they get pregnant. Also, something that fairly looks typically is not studied well enough is the presence of allergies. Chronic allergies or undiagnosed autoimmune issues can interfere with pregnancy. But if you've done your workup and you've been studied and you're healthy, even in your mid-30s or late 30s, I was 34 on my first pregnancy and 38 on my second. The only thing I can tell you what happened to me, I just was a little bit more tired in my second pregnancy. But it should not be an issue. So if you already had a pregnancy, you should be able to get pregnant. Check hormones. If you're not sleeping well, very likely you might have also problems getting pregnant. But go get checked. Get checked, and if things are all normal, say, well, I don't see no reason. Check for allergies. Check your thyroid, and maybe you'll find something there. And then here for later when you talk about C-section births. Let me see if there's more questions about it. My third C-section is on the 22nd. Any tips for quick recovery for mom? I think you said you would talk about C-section babies. Yes, quick recovery. It's here. Well, of course, rest sounds logical, right? It is important. And if your third baby, you might have a couple of others to take care of. It is important to get your nutritionals, rest, a good wound healing is very important, but that would be the things for a quick recovery. Take it easy. Take it easy, and don't do things by yourself. It's always good to let's follow what the doctor and your surgeon recommended. But those are the ones if you really want a quick heal. If you don't want a quick heal, you're going to be cooking, you're going to be doing, don't do those. Let people take care of you for that time. And then it said here, I'm going to the second question. I said no pacifier. Do you suggest no pacifier until baby learns to latch or none at all? This is what I tried to do, Erica. I tried to put the pacifier after she latched, since she latched really well. It's just that, and I will be honest, I really missed the pacifier. My husband and I went like, why would she won't take the pacifier? And it's just, I think, a matter about the type of baby that you have. Like the parenting, that website I told you, that the parent, she really is against pacifiers, and most true lactivists are too. I say do what works for you. As soon as you get a good latch, if your baby has no problem and if she takes a pacifier, I have a lot of friends who breastfeed successfully and the baby uses a pacifier. And it gives you a well enough rest. Because sometimes, and this is something that I'll tell you, my baby just wants the comfort. So whatever works for you is fine, but try to get a latch before. More so because of my first experience. I had a very hard time getting my first baby to latch well. So, and you ask another question. It says here, if our breasts don't lactate about 3 days later, how do we prevent hospital nurses to use bottles of babies? I don't understand. This is exactly what happened to me. You have to be very open, and so they have to listen to what you ask. The thing is, and this is, I like I said, I understand you firsthand, because this is, the nurses said, well, you're not feeding the baby. He's hungry. Remember the slide where I showed you the size of the stomach comparison to the amount that the baby needs? So it needs about less than an ounce per feeding. So don't get bullied. This is where we have to stay strong and just let them keep the baby with you. And let the baby just latch as much as you need, and be very clear about it, because if they interfere, and this is now where you have to check the type of training the hospital has. I'll search the specific name in the United States, which this, like, because this is the one thing that the hospital where I had my baby, 5 years later, they got trained in this specific form of skin-to-skin, kangaroo type, and they were now, with the lactation consultant, they were more to help you get that latch. The first time around, they didn't know anything, so that's why I got the baby with the bottle. Thank you. Have to go, Sylvia. Oh, awesome. Okay, so what do some people not always ovulate? People trying to get pregnant but infrequent ovulation. This could be hormonal. There's a lot. This actually is more of a difficult question to answer like this. But in summary, it has to do with your hormones. But it's also normal to not ovulate every time. So if this is happening more often, we do have to do some blood work, or some integrative physicians can do saliva tests. If you don't have that availability, even routine blood work could do fine to just get an idea how you're cycling. A lot of the information that a doctor can get is clinical. Of if you have painful periods, if you have abundant periods, those are typically signs of not ovulating. Let's say if there's polycystic ovarian syndrome, there's a lot of things. It's quite more complex, but there's a way to find out. Okay, and there's of course over-the-counter kits that tells you if you're ovulating or not. The important thing that I can leave you with is not getting overly stressed. Trying to get pregnant should be fun, should be something exciting. I know when it's happened, if a year, typically what is called infertility or having troubles conceiving is after a full year of unprotected sex. Sadly, a lot of the times, most doctors won't wait. And they, of course, it's a lot of money to go into fertility treatments. So give yourself a chance. Give yourself that full year. If it's not happened within a year, if you have the time, sometimes they don't want to wait. But the typical thing is to wait a year and then check your husband first. Sometimes it's a low sperm count. And we women go through all these unnecessary tests. They are very painful and expensive and bothersome. If sometimes we find out there's a low sperm count, that can be easily fixed with change of underwear, change in type of sports, eating. There's a lot of things that we can do there. So get your husband or boyfriend checked first, If that's okay, then we go into the woman. So um, I think that's it. I'm very grateful that for the attendance and for your time in this webinar. If you're interested in more subjects or specific subjects, please let us know, and I'll work harder to make a more like free-flowing webinar. Like I said, I get excited. I have a lot of information. I'm really passionate about this subject, and I'm glad that you stuck around and listened. Thank you so much. It's nice to hear your feedback, and we'll see each other soon, maybe. Thank you. Thank you. Have a great night. Goodbye.